denk dat je niet zo vreselijk veel macht hebt om dingen anders te laten gaan. Het gebeurt gewoon.
Maar ja, ik ben wel blij dat ik gewoon nog leef natuurlijk.
On voit l'être aimé complètement distordu et il est là, il est plus là, mais en même temps il est là.
Quando hai alle spalle un dolore, una sofferenza del genere, apprezzi anche le piccole cose. Non è scontato niente, non è scontato che respiri, non è scontato che stai in piedi e cammini, puoi correre, non è scontato vedere il sole, non è scontato niente.
Bijna verdwaasd rond, in een trance rond. Maar ik moet zeggen, de zorg eromheen is wel heel erg goed. En ja, het was een heftige tijd, maar wel een mooie tijd.
Welke gevoelens ik heb ervaren. Ja, je bent ontzettend nauw betrokken bij mijn vrouw, wat die meemaakt. En je kunt daar niks mee, maar je moet er zelf mee uit de voeten. En je hebt wel het volle vertrouwen, dat had ik wel steeds.
Io sono un medico di terapia intensiva, non un rianimatore, nel senso che lavoro con i neonati, quindi mi occupo di tutt'altra di bambini molto molto piccoli, non faccio il loro stesso lavoro, però chiaramente il rapporto con i medici è stato condizionato anche dalla mia posizione. Tra l'altro sono dei colleghi perché sono nel mio stesso, quindi da una parte ero sicuramente facilitata nel comprendere razionalmente quello che stava succedendo, cioè non avevo bisogno dei lunghissimi colloqui perché mi spiegassero per avere notizie cliniche, perché era più semplice riassumermi le cose. D'altra parte, dal punto di vista umano, dal punto di vista emotivo, questo non è servito a niente, anzi forse ha peggiorato le cose, perché sapevo cosa poteva sucedere e non volevo accettarlo.
Ahora lo que me motiva es mejorar la vida de la gente. Ya no es tanto la técnica, ¿no?, como cuando eres joven, porque llega un punto que la técnica es técnica y no tiene ningún secreto, sino las pequeñas cosas que pueden hacer que marcan la diferencia. El hablar con el paciente, con la familia, el hacer una educación sanitaria que nadie ha hecho hasta ese punto y tú no lo sabías porque dabas por hecho que lo habían hecho. Esas cosas son las que te motivan, el mejorar el cuidado del paciente.
Il faut faire du cas par cas, en fait. C'est primordial, parce que chaque histoire est différente. Et quand vous vous trouvez en tant que patient, en tant que famille de patients, dans cette situation, dans un univers où vous ne parlez pas cette langue-là, cette langue faite d'acronymes et de termes techniques que vous ne connaissez pas, quand vous vous retrouvez face au savoir et que du coup vous vous retrouvez impuissant, que vous vous retrouvez stupide, que vous vous retrouvez humilié, que vous vous retrouvez démuni, comment faire?
Jokainen lääkäri varmaan pelkää komplikaatiota tai jotakin, että mitään, niin ei hiffaa jotain juttua, mitä olisi pitänyt hiffata, joskin siinäkin auttaa se, että harvoin tekee yksin koko päivää töitä. Nämä tuli nyt äkkiseltään mulle mieleen.
And what scares me is that making those decisions and making those wrong decisions and the realization that that decision in 3-4 weeks' time, where you end up having a patient who, in effect, can be crippled by life-sustaining therapy, which may not have been in their best interests or their family's best interests. And that still scares me. I think it scares a lot of colleagues, but intensive care is much more multidisciplinary now, and I think that has helped our decision-making and has reduced that fear factor.
Honesty and humility go a long way. And most patients and relatives understand that we're also human and mistakes can happen and should be openly discussed.
Οι ασθενείς όμως έρχονται σε επαφή με εμάς, ιδιαίτερα αυτοί που βγαίνουν από το νοσοκομείο, πηγαίνουν σε κέντρα αποκατάστασης και ύστερα από πάρα πολύ καιρό έρχονται να μας συναντήσουν, γιατί ξέρουν τα πρόσωπά μας, τις φωνές μας, τον αγώνα που δίνουμε μέσα στο χώρο για να καταφέρουμε να τους σώσουμε, να επιβιώσουν και έρχονται να μας δουν, να μας γνωρίσουν από κοντά, να τους δούμε κι εμείς.
Together with my colleagues, in particular the nursing colleagues, we arranged a wedding for a patient who was at the end of his life and had decided to marry his long-term partner before he later died. And it was very moving to be part of this very special event in the intensive care unit.
It's a real privilege to be able to support a patient and their family through that, what I hope is the worst thing that ever happens to them in their lives, to be able to support them through that, hopefully to recovery, or to support them through managing a dignified death.
Il faut ramener la vie. Pourquoi est-ce que tout est si blanc, voire gris? Pourquoi est-ce que ce lino couine autant sous les crocs des médecins? C'est insoutenable. Pourquoi est-ce que tout est autant aseptisé? C'est pas 3 photos qui vont empêcher les gens de travailler. Moi, je pense que c'est important de ramener de la vie à cet endroit où on se trouve à la frontière au bord d'eux, on se trouve dans une espèce de no man's land où on sait pas sur quoi ça va déboucher, quoi.
La mia opinione della terapia intensiva è fantastica perché mi hanno salvato la vita e dopo 3 anni sono qui. Anche a un altro ospedale che mi hanno dato per morto, per fortuna sono arrivato in questa terapia intensiva e mi hanno salvato veramente la vita.
Solo belle cose possono uscire dalla mia bocca, ovviamente, perché senza di loro non sarei qui, ripeto, non sarei qui oggi.
Intensive care medicine allows me to learn something new every day. So every day I meet colleagues and I hear of their new technologies, new advances, and progress in their particular specialty. But most importantly, every day is a different day with new challenges, and I enjoy the interaction with my colleagues and most importantly with patients and their relatives. So it provides a great variety, it's different every day, and it's a specialty where progress is made on a regular basis.
Grazie perché mi hanno ricordato anche come si lavora. Cioè, io faccio questo mestiere, lo faccio da tanti anni, ci sono dei momenti in cui sei stanco, in cui hai le tue cose, nel senso che hai la tua vita, hai delle preoccupazioni, però io ero serena quando andavo via, non perché sapevo che non sarebbe morto, poteva morire, poteva star male, ma era nelle mani migliori. Sapevo che era nelle migliori mani e questo mi dava quel minimo di tranquillità che potevo cercare. È giusto che i bambini che mi vengono affidati e i genitori quando vanno a casa possano pensare la stessa cosa. Siamo nelle migliori mani, quindi dobbiamo sempre fare il meglio. Grazie a loro per esserlo il meglio.
So I am a full-time intensivist and proud to be one. We're all working together in a multidisciplinary fashion to fight COVID-19. Together, we are intensive care medicine.
Hello, I'm internal medicine specialist and I'm proud to be an intensivist. We intensivists are working hard to fight for COVID-19. Together, we are intensive care medicine. Thank you.
I am the editor of Intensive Care Medicine Journal and I'm proud to be an intensivist. We are working together to fight COVID-19 and to take care also of non-COVID patients. Together, we are intensive care medicine.
I'm a nephrologist and I'm proud to be an intensivist. We intensivists are working together to fight COVID-19. Together, we are intensive care medicine.
I'm an anesthesiologist and I'm proud to be an intensivist. We intensivists are working together to fight COVID-19. Together, we are intensive care medicine.
Great, ladies and gentlemen. It's my great pleasure to extend to all of you a great welcome for this ESIC webinar on ICU nutrition. Ladies and gentlemen, the title is Personalized Nutrition for the Critically Ill Patient. Are we ready? With this in mind, we recruited two outstanding speakers known for their clinical competencies as well as for research activities. The first speaker is Professor Pierre Singer from Tel Aviv, Israel. The next speaker is going to be Professor Berger from the Lausanne University Hospital in Switzerland. The first speaker, Professor Singer, is going to speak about personalized nutrition. He will give more detail about the needs of patients in this critical condition, as well as discuss the metabolic response, not only critical illness, but to nutrition in order to optimize nutrition. As the next speaker will focus more on detecting the most vulnerable patients in order to tailor, to fine-tune nutrition support in order to optimize clinical outcome. So ladies and gentlemen, yes, we are ready to personalize nutrition, even in case of the most critical illness. So it's really my pleasure now to invite Pierre Singer to deliver his talk. Right after his presentation, we will open the presentation for questions and we will together try to answer your question. So be welcome, relax, and take advantage to listen to Pierre Singer. Thank you.
Well, thank you very much, Claude, for this very kind introduction. And indeed, we will go through this presentation trying to understand better what are the challenges to achieve a personalized nutrition. These are my disclosures. And the messages of this lecture will be that to understand that really ICU patients are very different one from the other. And the needs are depending of different diseases, gender, nitrogen excretion, and daily variation that we will go into detail. And one of the keys of the solutions is indirect calorimetry, since it's can be used as a point of care to guide the medical nutritional therapy, as well as the evaluation of the nitrogen expression, trying to find out how to provide the best protein intake in these patients. Well, like Claude Pichard and Metteberger, that are co-authors of these ESPEN guidelines, we were trying to give in a general way what should be the recommendations to feed these patients in the ICU. But ICU patients are like a big forest with a lot of trees. And it's difficult to give one only guidance for all these patients. And we may miss some effective therapies. In fact, we have different etiologies, we have different intensity of organ failures. The patients are coming with different genetic and epigenetic profiles. They have some metabolic heterogeneity. It's depending of the dose, of the timing, of the route, of the complexity and the polymorbidity of the patients. And of course, we know that ICU patients are changing. So it's not possible to have one answer for all these situations. How can we understand that better, since we know that the intensity of reaction to sepsis can be so different, for instance? Well, we can start from the beginning, which is the simplest way, looking to the etiology or the reason of admission of the patient in the ICU. And of course, we will easily recognize the obese patient, the frail patient, the septic shock patient, the renal patient, or the multiple trauma patient. We may also easily recognize the time of evolution of these patients. It can be at the beginning, at the early phase, but also post-acute phase can be relevant to prescribe the right dose of nutrition to administer to the patient. The patient can be normally nourished, but he could also be severely malnourished from the beginning of the ICU. And of course, this will also direct our medical nutritional therapy. The simplest questions may be energy and protein, how much to prescribe? Well, if it is available, we should use indirect calorimetry, and I will show you why. And we should also try to give enough protein to these patients. Why to use indirect calorimetry? Because of some studies that have been showing that one of the big dangers is overfeeding. And this is a study we performed in 2016. And we showed that actually when the patient is receiving more than 100% of his measured energy expenditure, actually we can see that the rate of mortality is significantly increased. This association between the amount of energy that is administered and survival at the two extremes of administration of energy are very important. And if we are doing wrong by this prescription of giving energy, we may harm and not improve the outcome of the patient. So we prefer to target energy below the 100% measured energy expenditure. Let's go into three specific cases: the trauma patients, the obese patients, and of course, what is very much in study today, the COVID-2 patients. Well, it is clear that we know that patients, according to the disease, have a high variability of energy expenditure. Patients with burns have a very high energy expenditure, followed by multiple trauma, the septic patients, muscle relaxants, shock, vasoconstriction, for instance, are decreasing energy expenditure, while, for instance, fever, inflammation, patients that are awakening or making shivering may increase energy expenditure. It's very difficult to precise how much the patient is needing if we are not measuring it. So the first message would be measure indirect calorimetry to create a best target to your patient. If you don't have a measurement, use a lower energy requirement to avoid overnutrition. Now, regarding protein, how can we decide how much to administer? Hypermetabolism is not associated always with hypercatabolism. This is a good example of a recent study that we didn't publish yet, showing two groups of patients, one with a nitrogen output of more than 15 grams per day, compared to another with a lower nitrogen excretion, despite the fact that their energy expenditure is not significantly different. The patients that have a higher nitrogen excretion are younger and they have a lower BMI. Michael Hismayer, in one of his studies regarding nitrogen excretion, showed already that the younger patients have a higher nitrogen excretion, mainly later at day 14, but also at day 7. The older patients have a lower nitrogen expression. This may be explained by the fact that the older patients have a lower muscle mass. The patients who have a higher weight or height have a higher energy expenditure, nitrogen excretion. The older, of course, have a lower nitrogen excretion. Gender is also influencing the nitrogen excretion, showing 1.2 gram of nitrogen excretion lower in comparison to male. Remarkably, the patients that are survivors have a higher nitrogen excretion, and this, of course, may be explained by the fact that these patients have also a higher amount of muscle. The muscle mass, the muscle quality, they are very important in the prognosis of the patient. If a skeletal muscle density is lower, the survival will be significantly lower for these patients. And if you give more protein to these patients, you can see that there is an association to an improvement of the survival in a significant way. And this study by the Peter Weiss team is showing also that when you exceed a certain amount of energy above 100% of the resting energy expenditure, you may increase the risk of mortality, confirming other data I showed you before. However, not all the patients are reacting the same regarding protein. And from the same team from Amsterdam, you can see that the patients that have a high intake in protein and non-septic are improving their survival, while those who are in a septic condition have no effect, are not receiving any effect or beneficial effect of protein in these conditions. So these patients have an anabolic resistance, are not able to enjoy the amount of proteins that have been administered. So the message number 2 is, yes, personalized protein according to age, according to gender, according to frailty and decrease in muscle mass, according to sepsis, and also according to nitrogen excretion. The route of administration has been unanimously approved to be enterally professional. And if the ESPEN, as well as the ESIGM guidelines, are telling us that we should do an early enteral nutrition therapy for these critically ill patients, well, it's not possible all the time. And we have to look at the reaction of the patient. Feeding intolerance can be frequent, and vomiting and high gastric residue volume could be dangerous for the patient and increase the risks of aspiration. On the other hand, diarrhea or bowel distension are decreasing the chances of the patient to absorb the nutrient that we are administering. There is a risk of increased abdominal pressure. There are other risks of GI tract bleeding or constipation. A lot of GI tract signs are impairing our ability to administer adequately medical nutritional therapy through nasogastric tubes. And there is a tango between the GI tract and the enteral feeding. And we try to administer, and sometimes it's working. If we succeed to improve the calorie and the protein intake by enteral feeding in our patients, this post-hoc analysis is telling us that we are also improving the survival significantly. If we are not succeeding with enteral feeding, parenteral nutrition is an option, and this should be considered, but really by a specific evaluation of each patient, trying to finally administer the amount of energy and protein that the patient is requiring. This is an example of measuring energy expenditure and progressing with the enteral feeding in a nice way to reach the target at day 4. This is another example showing that in fact, these are the measurement of energy expenditure. We fail to administer enteral feeding, reaching the target, and then we go with parenteral nutrition, and together we are able to reach the target. This is a good example of supplemental parenteral nutrition. Of course, we have to follow what we are doing. We have to be afraid of refeeding syndrome. We have to follow the electrolytes, the liver function tests, the lipid profile, urea, creatinine. And we have also to look closely to the patient when he will improve, when he is able to put himself in a negative fluid balance, recovering consciousness, improving the albumin levels, decreasing his requirements in hydrotrophs, and be able to be weaned from the ventilator, and so on. These conditions, don't forget to change your prescription and go into a recovery period, an anabolic period, and then patients will be able to better enjoy higher amount of protein. So in conclusion, ladies and gentlemen, the personalized nutrition is possible. Try to use indirect calorimetry to target energy, and also try to target protein according to the clinical evaluation. Thank you very much.
Well, thank you, Professor Singer. This was a crystal clear lecture. Thank you so much. So, ladies and gentlemen, you now have the possibility to raise questions, either directly or using messages or whatever social network you are using. The team should receive your question, and of course, we will try to address and answer to them. So just looking at any message being received. Well, in between, Professor Singer, we all know that you are routinely measuring energy expenditure using calorimetry in your ICU. During this COVID crisis, did you measure energy expenditure in your patient? And if yes, when did you do it?
Well, the measurement of indirect calorimetry of energy expenditure during the COVID period was a little bit complicated in our setting, because our hospital decided to locate all the COVID patients in a specific hospital and not in my department. And in this specific unit, they were using models incorporated in the monitors. And these models were able to assess continuously energy expenditure in COVID patients. Not all of them. We had also a limited number of patients. And our observation was that these patients, mainly at the early phase, were very much hypermetabolic, reaching 2,500 to 3,000 kilocalories.
Okay.
Another way of seeing the monitors that has been proposed by some groups was to connect the device with a lot of precautions, because definitively we were afraid of the dispersions of the particles and the viruses all over around, and therefore there was a process putting the respirator on a standby position and clamping the tube, so disconnecting the humidifier and the device for the measurement, and so reconnecting everything and restarting and then starting the measurement.
Thank you, Professor Singer. I have a question here with regard to the use of enteral nutrition in the prone position patient. How do you adjust in case of symptoms of intolerance? I suppose the question is about vomiting during this situation. What is your recommendation?
In this COVID period, we were using enteral feeding, using also patients in patients that were in prone position, and the tolerance was quite good and it was working well. Of course, when the gastric residue is very important, we were very much cautious in this situation, and if there was serious signs of gastric intolerance, we were switching to parenteral nutrition. However, some of our colleagues were using, when the patient was returned to supine position, positioning the tube into the duodenum at the bedside, not using gastroenterologists or, of course, radiologists, but using bedside techniques. And if it was successful, introducing the tube to the duodenum or to the jejunum was helpful. But in case of suspected risks of or serious risks of aspiration, we were very keen to go to unused parenteral nutrition.
Well, thank you. Another question is, what is the level of evidence for indirect calorimetry used to improve patient outcome?
This is an important question, of course, because indirect calorimetry is a tool for monitoring patients, and it's difficult to have evidence for a monitoring tool. There is no evidence for ECG monitoring. There is no evidence for saturation, SpO2 monitoring. But I would not escape this question because it's a tool, it's a point of care, and therefore it's used to create to prescribe in the best way the amount of energy that we want to administer. So I think that there are quite a lot of evidence showing that overfeeding is harmful for the patient, is increasing problem of weaning of ventilation, an increase in infection, and an increasing in liver disturbances. There are also some trends to show that there is an increase in mortality when you don't use indirect calorimetry. There are few papers looking to that in a specific way. We just had a paper accepted called TICACOS 2.0. TICACOS, it's an international study trying to demonstrate the utility of indirect calorimetry in critically ill patients. We didn't reach significance, and actually, when we look to the results, we should have included more than 1,000 patients in each arm. So it's difficult to demonstrate in a very large prospective randomized studies. However, we hope that using meta-analysis with all the studies that are nowadays available and using indirect calorimetry, we may reach a significant signal.
Well, thank you, Professor Singer. A last question on your side. You distinguish between acute, early, and late phase after admission in the ICU. How actually do you practically distinguish these two phases?
Well, this is also an interesting question. According to our experience of measuring repeatedly resting energy expenditure, as I showed before, we can individualize the 2 first days as an acute phase when the energy expenditure is lower, and then it's increasing. The differences are not so big, but they reach 10 to 15% differences. There is definitively no ultimative tool to know exactly when the patient is switching from the acute phase to the post-acute phase. And this may change from one patient to the other. We know that a patient in critical illness is admitted and he has to be resuscitated. We know that during all this period of resuscitation, we are in an early phase. When the patient is stabilizing, he is now in a stable dose of noradrenaline, vasopressin, his oxygenation is also stabilized, his lactate is decreasing. We are going into the post-early phase, and we are going progressively to stabilization. But today, we don't have the key to know exactly when the patient is changing phases.
Okay, thank you, Professor Singer. This was really a great moment to share with you all these important points. Nobody is there to give you a good hand, but I do it myself. So thank you and congratulations. And I would like to invite Professor Mette Berger from the Lausanne University Hospital in Switzerland. Professor Berger is going to speak about detecting high-risk patients and adapting nutrition therapy according to this evaluation of risk. So, Professor Berger, the floor is yours. Thank you.
Thank you. The presentation of Professor Singer was very interesting, and I'm going to try and complete what he said. Good afternoon, everybody. So we're going to talk about detecting high-risk patients. My disclosures, the very important one is to be member of the ICU guidelines in the 2 societies which matter to me. What are we going to look at? Well, I'm trying to convince you that patients differ and that risks vary over time. And we have to consider what happened prior to hospital admission and assess the patient. And after the patient is admitted, look for the risks immediately after there. We then will watch for underfeeding and overfeeding and potential for micronutrient deficiencies. What do we know? Actually, this very important paper was published by the Nutrition Day group last year, and it shows something which matters to our ICU patients. You look at this, eating last week. More than half of the patients have eaten less than normal, and this goes to nothing. This is related to outcome, and depending on how little you've eaten, you will multiply your risk of dying by 2, 3, 4, and even 8. So you put yourself at risk due to disease for not eating. And this matters because this is actually integrated in the European Nutrition Risk Screening Score. And for the ICU, we have set in the ICU guidelines of ESPEN a cutoff at 5. This study includes patients who are long stayers in the ICU. It comes from our ICU where the patients were not very well fed, but the same relative underfeeding impacted much more on outcome in those who had a high risk, who came in with no reserves. These data come from China. They are not yet published. They looked at 400 patients who were real sick, and they scored them with the NRS, and look at the mortality of those who have 5s and more. Clearly, this will impact outcome. And then comes into the ICU. Feeding is not always easy. And this is the cumulated risk of complications coming from our ICU and from Pierre Singer's ICU. We published that in 2006 using exactly the same methodology. We were using DATEX indirect calorimetry to calculate goals, and we had metavision to see what the patient had got of feeding. In both ICUs, a modest deficit during the first days was not a problem. But the risk of complications related to underfeeding, such as pneumonia, leaks of sutures, etc., were increasing by minus 8,000, which corresponded to cumulated deficit at minus 100 kilocalories per kilo body weight. And then when patients reached minus 10,000 cumulated from start during the first week, all had a form of complication related to that. Well, the problem starts here by minus 6,000. Does it matter? Well, if you look at data from the United States in a surgical ICU, the title of the publication tells it does. They took this minus 6,000 calorie cutoff, looked also at proteins, and the patients who had a lower energy deficit than 6,000 had a lower mortality, had a lower 30 days mortality, but especially were much more likely, 3 times more likely to be discharged home. So we can do something. And then we can do something respecting timing. Because actually, for muscle, the clock starts ticking from admission. And something happens very early on, which is the initiation of catabolism. And you possibly have read this landmark paper showing that by day 10, the patients have lost between 15 and 20% of their muscle mass. So what do we mean with the clock ticks? Actually, during the early phase, the patient is in shock, has a sort of metabolic shutdown while taking care of neoglucogenesis. When the days pass and your patient hopefully responds to therapy, the patient will get out of this very acute catabolic phase and progress slowly or rapidly, depending on the severity of disease, into anabolism. And of course, this should be present during the late phase or the rehabilitation phase or in chronic disease. What happens during this very early phase? This paper comes from Lausanne. At a time we were a surgical ICU with very poor enteral feeding protocol, and we did tracer studies in young patients. They were 40 years, trauma majority, measured metabolic rate with delta track, 1800, modestly increased, and glucose turnover showed that they were producing 3.1 milligram kilo minutes, which by their weight translates into 310 grams of glucose per day, roughly 1,200 calories. Look there. The patients were covering 2/3 of their needs, but this had a price. And this was roughly minus 120 grams of protein lost per day. This means half a kilo muscle lost per day. These are these patients I just showed you. We recently repeated a turnover study in another category of patients, 65 years old, ventilated, partially fed. They were producing 180 grams per sugar a day. Later, down the road, while they all were fed, they continued to produce 110 grams. We know by physiology that the body is taking care of this production. So this is the endogenous glucose production profile over time. And you see that the most acute is here. So if we want to prevent underfeeding and overfeeding, we should integrate all these informations. And if we know that, well, first they are low, then the energy expenditure increases. The endogenous energy production looks like this. Of course, this is not exact, it's conceptual. If we want to prevent overfeeding, underfeeding by full early feeding, it's not a good idea. This is what happens if you do that. So the prevention of underfeeding should integrate this early energy production you cannot stop by feeding. How should you do it? Professor Singer told you that we are recommending actually enteral feeding as first. And this led actually in the 90s to condemning parenteral nutrition. And actually now in the 20s, we have come a little bit back. Why? Actually, we know that there is nearly equipoise between parenteral and enteral. This trial, called the Calories trial, was actually including 2,400 mechanically ventilated patients, and they were randomized to non-indirect calorimetry guided feeding, but giving feeding, full feeding from first day. There was no difference in mortality, but in the parenteral group, there was a significant advantage in terms of less hypoglycemia and less vomiting. Okay. The Lancet was published another paper called Nutrirea. Also 2,400 patients, but more severe, in septic shock. They randomized them to parenteral or enteral from day 1 and managed to nearly full feed them by day 2 already. Actually, there was a higher risk of digestive complications in the enteral group, with more vomiting, as in the previous study, more diarrhea. Well, this is a problem for the nurses, more work, but also more bowel ischemia and more severe acute colonic pseudo-obstruction. Clearly, if you force feed some of the patient early on by either route, it's not real good. Again here, no difference in mortality. We conducted in Switzerland 2 consecutive trials. The hypothesis was that acute underfeeding beyond -4,000 would result in alterations of immunity. And we took the patients who were not covering enteral nutrition, being enteral nutrition convinced people, but we looked at day 3. And if it was not reaching 60% of the needs that we then had measured by indirect calorimetry, we delivered complement parenteral nutrition to cover measured energy expenditure. And we hypothesized this would maintain immunity. We used standard parenteral nutrition industrial solution. We delivered micronutrients to all and no specific addition of any type. It looks like that. Day 3, not achieving 60%, calorimetry guided goal by combined feeding or continuing pure enteral feeding, and then we looked at what happened thereafter in terms of infections. And indeed, we showed that with an intervention here, where we avoided overfeeding, we prevented infectious complications. This is a bicentric trial. It's Geneva-Lausanne. So there are differences between the hospitals, but the strategy was exactly the same. And actually, we had nosocomial infections reduced by 1/3. The second trial, which was done on exactly the same design, included this time traces, and you saw what we measures of endogenous glucose production. The nutrition strategy did not impact on that, but it impacted on inflammation and immunity. Inflammation. The patient who were on supplemental parenteral nutrition had a significant reduction of cytokines, including on picograms per liter in the intracellular tests, reduced TNF-alpha, also much more significant than in the patients who were not having this. And we had fetal hemagglutinin responses, which were significantly improved in the patient having benefited of this special feeding. An advantage which we were not certain about, but which we investigated and proved to be true, that was that due to the reduced risk of nosocomial infection, we had a 3,300 francs per case reduction in costs, despite having additional parenteral nutrition to some patients. So this was reducing the costs. 10,000 kilocalories reduction of cumulative energy deficit reduced nosocomial infections by 10%. Regarding micronutrients, they all received some. Why? Because the micronutrient status is threatened in critical illness. Well, pre-disease deficiency, and then there is oxidative stress, which requires adequate endogenous response, inflammation, which redistributes the micronutrients, and there are losses in some patients due to CVVH, due to drains, and so on. So there are really increased requirements in a threatened status, and our nutrients are not providing much, especially if your patient fed enterally is not receiving more than 1,500 calories, you do not cover the basal micronutrient needs. And this we showed by balance studies where we have CVH effluent losses that are continuous over time of actually all the water-soluble micronutrients. We are delivering enteral feeding. Well, actually, we have to complement that. And some are deficient, so we have to replete. We're not going for any supplementation because the high doses incur the risk of toxicity. But we always deliver some intravenous micronutrients to our patients to enable substrate metabolism, but also to cover the increased oxidative stress needs. We do not at ESPEN encourage the high-dose monotherapy. It's just providing the nutritional or slightly above doses. If we progress nutrition during the first day, we are below, and this is during the maximal oxidative stress period. And we encourage monitoring. This study is still not published. It is a survey, one-day prevalence survey, that was conducted by the men's section of the SICM. And we had 59 participating ICUs from 23 countries. Altogether, 880 patients were present on D-Day, and only 76% had phosphate determination, which was a surprise to us. We thought more would have. Of those patients having phosphate determination, 15% presented hypophosphatemia. Moderate occurred as a median by day 5. Severe occurred until late, but as a median before day 6. It was essentially associated with continuous renal replacement therapy. So, knowing all this, we know that the patients are at risk of many sorts. We now know, and this was not integrated before in our knowledge, but has explained many of the bad results from many trials who were well conducted, but who did not consider this. There is an early endogenous glucose production, which abates depending on severity of disease. Energy expenditure is not covered by that, but to avoid exceeding, as I showed you on the previous slide, we are encouraging to test progressive early enteral feeding, starting according to guidelines by SICM and ESPEN during the first 24 hours in the majority of patients, and ramped up. We can then advocate high protein, lower energy solutions. Time progresses, and actually, if the gut of your patient does not accommodate any enteral feeds or sufficient feeding, if you have the measured value, you should complete to that value by supplemental parenteral nutrition. If your patient is doing well on enteral, fine, no need for any further. So by doing this, you prevent any severe underfeeding. You remain below the cutoff of minus 6,000 that was shown to be valid in other parts of the world, and you do not go into severe deficiency. So to conclude, there is no single strategy for all patients. It's true for the route, for the energy, for the proteins, for the micronutrients. But we know that for all patients, the pre-admission status matters. And if your gut is not, or the gut of your patient is not accommodating enteral nutrition, parenteral nutrition is as good as that, because it's worse to get into deficiency. It's important to consider time. Endogenous glucose production is something that we do not have no tool to monitor yet. We are searching for it. But this is the reason why we empirically ramp up over the first 3 to 4 days, whatever the route, to prevent early overfeeding and prevent accumulation of deficit. We provide separate micronutrients, generally by the intravenous route, because the feeds are insufficient. And then we evaluate and monitor what is required. And for that, we use indirect calorimetry whenever possible. So if you have questions, I'm happy to take them.
Well, thank you, Professor Berger. This was really a wonderful, very rich presentation with practical recommendation at the end. I really enjoyed listening to you. Of course, this presentation is now open to questions. Well, they are probably coming very soon. I have a question for you. Would you distinguish the way you prescribe nutrition if you consider patient being vulnerable versus not vulnerable at the time of admission? In other words, do you really stratify them into vulnerable and not vulnerable to define your strategy?
Prediction in ICU is something very difficult. I have done several randomized trials where I was trying to select the patients who would stay 10 days in the ICU. Prediction is poor.
Mm-hmm.
So what we try to do is when we see a patient who is on mechanical ventilation, well, this is already a criterion, a severity criterion, and where we see we won't extubate this patient next day, we should then start prescribing. We should assess at the same time. The NRS score is calculated during the first 48 hours and is very rapid to do. So when disease progresses, if a patient does not recover, he will anyway, by protocol, get between day 3 and 7 an indirect calorimetry, depending on weekends, availability of people, and so on. But we start the same way, and we should take care specifically of those who start prolonging their stay. These are the patients where you should not give up, but you start in all, and you go for measuring and looking at what you've really been delivering to these patients, and you look simultaneously at the condition of your patient, and by that you adapt. So we have now been changing our protocol because I showed you our bad data from the first trial where Marina Viana did this work. We changed our protocol to improve actually our feeding, and we did exactly that. We did it in all, and we have managed to increase the protein delivery and energy delivery just by having our dietitians being really around from the first day. So this means that we should be careful as soon as the patient is on mechanical ventilation and prolong his stay.
Okay, thank you. Here is a question from the audience. Do you give IV micronutrients supplements in all of your patients with enteral nutrition not reaching 1500 kcal per day?
We have a protocol where intubated patients get 6 days of our stress profile, which contains one Adavan, one Sanavit, an addition of selenium and thiamine and vitamin C. And this is independent of the feeding route and is of course continued if the patient is on parenteral. But all get that. And when the patient is out of this period, if on enteral feeding, we take a multi-micronutrient supplement that our nurses dilute in the enteral feeds. So even over 1500 calories, they get. We have Supradin in a hospital diluted in their enteral feeds daily until discharge from the ICU.
Okay, thank you. A last question we can address. How do you modify providing nutrition in COVID patient, particularly if you see patient with cytokine storms?
Well, I have seen no cytokine storm myself, so, because this comes through the lab. But what we have done is that we have actually, knowing that people were coming in to assist who were not trained in critical care, we made our feeding protocol even simpler. They were as soon as they were intubated, my team, my people just initiated nutrition the way we do, which is ramping up over 2 to 3 days. And we were targeting the first week for 20 calories per kilo. And well, we did not always manage to cover the protein needs because these sedated patients were on high doses of propofol. So this took, as we integrate all the inputs to the patient, this took a part of the place for 20 calories kilo. And then empirically, and we did not measure by indirect calorimetry, we actually increased to 25 in the younger patients, staying cautious with the elderly patients. So we know we have possibly been below their needs, but we considered it more important to be systematic and to avoid, in the very hyperinflammatory and cytokine storm period we know about, to avoid exceeding the minimal needs. So we actually were more scared about overfeeding than of modest underfeeding, but provided very efficiently feeding to all. And I've been looking at the data of our 100 first patients. I was really surprised at how efficient early initiated enteral feeding was at covering the prescribed goal.
Okay,
and we've
thank
had
you.
a response. Actually, these patients have been increasing their prealbumin values in a way we had not seen before. A very amazing and rather rapid response within 7 to 10 days. So
Thank you.
we thought we might have avoided trouble with people who had limited training.
Well, this is generally true for all our activities. Well, thank you for this last comment, Professor Berger. Well, it's time now to play my role as a moderator to make sure we will end up in due time. Both of you have been fantastic, making sure to have clear messages, making sure that it's practical and can be used for daily life. I have to apologize for not having been able to address all the questions we received. Well, thank you to the audience for such an enthusiastic reaction. I hope that all of you will stay healthy. I wish you a great future And it's also time for me to thank Nestle Health Science for having supported this session, extremely useful for education and interaction among colleagues around the world. So thank you to all of you. Have a good end of the day and goodbye. Thank you.